So let's talk a little bit about GLP-1s, the peptide. And then the other thing I want to make sure that we hit, and you've said it a couple of times with you've said microdosing or like individualization for the patient or patient, like more of a bespoke, personalized protocol for each client, which is the right way to do things. And let's talk a little bit about the sort of blasting the receptors and the receptor fatigue and the standard dose that we are seeing with GLP-1s and why that is often associated with some of the big, like the black box the thyroid cancers and the nausea and the vomiting and the skeletal muscle wasting. And I was just reviewing a piece of research from the University of Alberta talking about cardiac tissue loss, right? So what are we getting wrong from a dosing perspective and maybe patient management perspective around some of these GLP-1s? And then let's talk a little bit about the perimenopausal munchies and how this can. I've heard you talk about it as I think you've called it the thickening,
yes,
which I really like. So we can talk a little bit about the thickening. Yeah, the thickening. Yeah.
Yeah. So GLP-1s are a naturally occurring peptide in our bodies. They're secreted by our stomach, our L cells in our stomach, and they're also manufactured in the brain. They're created in the brain, and they're used in the brain.
Just like serotonin, by the way. 90%. I know everyone's like, serotonin's made in the gut. It's like, no, RAF nucleus in the brain, also there. Okay,
yeah,
go on.
Yeah.
Sorry, that's my little accent.
Yeah. And I love it. I know it's interesting. The online phenomenon is interesting, watching people just grab things and run with it without any further knowledge of biochemistry or physiology or any
sound bites. Well, sound bites are really easy to understand, right?
Yeah, it's true. My husband sometimes will come home and say, "Did you know?" And he'll tell me some random thing he saw on the internet, on Instagram. He saw it on the Instagram. And I look at him and I'm like, are you kidding me? Like, are you effing kidding me right now?
Do you know who you're married to?
Like, what? Where are you getting this? Like, why would you even for a millisecond believe that nonsense? And he's like, well, I don't know. And he's a really smart guy, so this doesn't happen very often, but every once in a while. So I know, even the smartest. Anyway.
Okay, peptides.
Okay, so it's a GLP-1.
Yeah.
It's a peptide. It's actually a signaling peptide hormone like leptin, like ghrelin, like insulin. Like glucagon, these are signaling peptide hormones. A peptide is just a string of amino acids put together. My argument is that most of my patients' guts are trashed. Most people's guts are trashed. And as we age, we have gut lining atrophy as well. So I started wondering, I wonder if people are having a functional deficiency of GLP-1. I wonder if they, somebody would say with like ulcerative colitis, for an example, or someone who has a chronic history of IBS even, their L cells probably are a little pooped out or petering out, maybe not doing their best, right? We know that there's other cells of the gut that aren't doing so well. So why not the L cells too? So there's that. And then in the brain, I started wondering, well, I wonder if we get even a GLP-1 resistance, like we would like an insulin resistance. We know we can get cortisol resistance in the brain, if you know. So those are just some of my initial thoughts. And no, we don't have data to support all of this, but these logically thinking, when you understand how things work, it would make some sense, right? So the pharmaceutical industry has made these peptides. Normally they're made by our body and then they're out of our system very quickly. We have data to support that those who have fatty liver and type 2 diabetes are GLP-1 deficient, essentially, or they become that probably functionally. I don't know if they're born that way or if there's any
like
kind of
NAFLD, like non-alcoholic fatty liver, or also from cirrhosis. Yeah.
Yeah. And perhaps what comes first, is it the horse before the cart, whatever, chicken and egg? Like, I wonder, are some of these people born GLP-1 deficient and then they end up like that? So I these were some of my initial thoughts. And I still wonder. But we have
also genetic, sorry to interrupt you, but there must be some genetic SNPs that are,
I'm sure
providing some variances in the population. Yeah.
I'm sure. I grew up with an obese sister, and something was from all of us very lean. Something was different about it. There's always something, like, that wasn't just her fault. She wasn't just lazy and gluttonous. Something was wrong.
Right.
And it wasn't just her thyroid, something, and I think GLP-1's a player here. So then beyond that, the pharmaceutical industry tweaked it so it had a longer half-life. So it lasts in the body for a week versus a few hours. And they just happened to find that it had really powerful impacts on blood sugar regulation and metabolic health. And also then later than that, even, this peptide's been around this family, I should say, has been around for 20 years. It started back as exenatide, and we've had just a new generation come out every few years of a more tolerable version, kind of a cleaner version, easier to administer versions. And then we land on the last few years, and they discover that we're seeing incredible weight loss in our type 2 diabetics that we're using this for. So let's FDA approve it for weight loss. And that's when everybody seemed to go insane. Like everybody seemed to suddenly have a fit about it. And here we are. And it's a few years later, and I've been talking about it for the last year and a half. And, I do feel like I've at least brought an awareness about people are jumping on it. And I think it's a lot more people are being helped, because I don't think that the initial starting dose for most of these peptides is something that is a comfortable starting place for a lot of folks, especially folks like you and me who maybe want to use it for other reasons, or perhaps we just need a much smaller dose. And so my argument is for inclusivity at the end of the day. Like, I think putting somebody on a dose of something that makes them throw up for weeks on end and potentially become intolerable and have to come off isn't a really great way to do things. Like, I would argue that perhaps there could be a more individualized, personalized dosing available for folks. And right now, the only way we can get that is with vials. I know that Eli Lilly has the Zepbound vial, but we can also find compounded vials. And so that's how we got here. And my other argument was that I think that a lot of people are being overdosed, and that's why we're seeing these horrific side effects.
Yes,
and I haven't seen any of them in any of my patients. I have not induced anything, maybe a little bit of transient loose stool, because my daughter calls it the purge. As you go on a GLP-1, your microflora, your microbiome shifts. We have data to show that it shifts to a more ultimately favorable microbiome, and you will potentially purge out for a couple days. But I haven't had anybody have it be even uncomfortable. Like, nobody's spending the day on the toilet. Like, that's unnecessary. That's unnecessary aggressive dosing. And I think that most of the problems we're seeing is a dosing and management issue. The other part is that, let's talk about the thyroid cancer real quick, just so we can hit it. The data that's come out most recently is not showing even correlative to linking GLP-1s to thyroid cancer. There's no causative data, and there's not even any correlative data.
I don't think there's human data. Is there human data?
Okay, so the black box I'll get to, but the actual real concern at the end of the day is, if I stay on this for a while, am I going to get thyroid cancer? And so far, even in the last few months, they have looked at countless studies where all of these studies anyway they're looking at patient chart notes over time, and patients who happen to be on semaglutide versus those who are not. There's just not a link in the thyroid cancer division. So I'm not concerned. However, I'm not your doctor, and I can't give you medical advice if you're listening. So if you have thyroid cancer, you've had a history of thyroid cancer, a family history of thyroid cancer, absolutely talk to your doctor. In all cases, talk to your doctor. This is up to your risk tolerance. But that doesn't mean it's out for you. It just means proceed carefully. We don't have any correlative or causative data in humans. In rats, that was the black box warning. They did a rat study. They gave them supraphysiologic doses, like really high doses of GLP-1s. Rats develop spontaneous medullary thyroid cancer. The control group also developed spontaneous medullary thyroid cancer, and they slapped this is also a very rare cancer in humans, but a very common cancer in rats. And then they slapped a black box warning. So there's literally no data to show that GLP-1s cause thyroid cancer in humans. So I will leave that there. And then the muscle part, anytime you put somebody on a severe caloric restriction, I'm sure you've said this to your audience as well, and we'll just drill it home again. Anytime you put somebody on a severe caloric restriction, whether that be through dietary interventions, bariatric surgery, or a GLP-1 at too high of a dose, and you crush their appetite into them not wanting to eat, they're going to become malnourished, and they're going to waste away, and they're going to lose roughly 25 to 35% of their lean mass. Muscle is but one part of your lean mass. It is not all of it. And so they're looking at lean mass loss. I think even one study showed 40%. A lot of these studies did not have the patients exercising, or the control subjects in the study exercising, and they were on really high doses. And again, it's apples to oranges, because when we're talking severe pathology of severe obesity and type 2 diabetes, and I will repeat this till the end of time, type 2 diabetes is a severe condition. People just have normalized it because it's everywhere now, but it is a severe medical condition. It's a severe pathology. It's the most severe form. Your mitochondria and your metabolic health are devastated by the time you get that diagnosis. So they're using crazy high doses in these studies, and I'm over here arguing like, hey, us middle-aged girlies also have some insulin resistance, and we also have some autoimmune disease, and we also have some cardiovascular issues. could we not just potentially bring in a more personalized dose to use for us? And that has garnered me a lot of attention, but also a lot of heat and pushback, because for some reason, some people's brains can't compute. And they're like, I'm trying to show them good studies coming out on Alzheimer's disease and neural regeneration. And they're like, weight loss is just eat less and move more, and you're just lazy. And I'm like, can you guys not get past? Like, can they
also, if you say that, you don't understand metabolism.
I know,
just
like,
yeah.
Could they just not get past, though, they're just barking like little parrots online. And I'm over here like, look at this. Like, I really hope and some of the big influencers that we know and love who are very anti-Ozempic, I certainly hope nobody they love ever ends up with Parkinson's or Alzheimer's and might need to utilize one of these GLP-1s. It's like it takes me back to what I was saying earlier. What I did to myself, what happened to me in my childhood and my teens and my 20s set the stage for how my metabolic health was going to be in my 50s. No matter how diligent I was in my mid 30s and all the way through my 40s with all of my, good lifestyle habits, it still kicks you in the ass. Maybe not. And it's just bizarre to me that people wouldn't be open-minded to utilizing tools that have a proven track record. We've got 20 years of GLP-1s, safe, fine. Again, people didn't lose their minds until the weight loss topic came up. And that just tells me that we potentially have a very severe obesity bias in this country.
We do. And I think nobody bats an eye when a type 2 diabetic gets their insulin levels increased. No one is like,
they get on
he needs more.
5 other I call it the diabetes industrial complex. It's very profitable for a lot of industries. There's a lot of people making money off of fat Americans, and a lot of different industries profit from our addiction to food, from our hip replacements and knee replacements, from our, the pain. There's a lot of pain with aging. People don't want to, I know you understand this, but very few do, that, 1 out of 5, they say 1 out of 5 to 1 out of 7 patients of any age will present to any doctor's office with pain as a chief complaint. And we know how to handle pain to some degree with the tools we have. There's more available, right? Like my early days of practice, my first 5 years, you know what I did? I made everybody run a standard blood panel. It was like a comprehensive functional medicine blood panel. Everybody, they had to agree to this or I wouldn't be their doctor. They had to run a blood panel. They had to run a gut test, a full GI panel. And then I was correlating their labs in real time with what I was feeling on their spine. So I could tell if there was a lot of tension, for instance, in the TL junction or around that bra strap area, that was always thyroid. The tension in the calves, that was always thyroid. And I was starting to correlate these physical findings with the labs that I was seeing in front of me. And I learned a lot. I basically just made every patient do that so I could see what everybody was walking through the door with. And at that time, this is 20 years ago, everybody had metabolic dysfunction. Everybody did. I didn't need a study from 2018 to tell me that 94% of US adults are busted. I saw it every day in my practice in their labs. And you can see it on their body habitus, So we're in a pickle. And I was trying to sound this alarm 20 years ago. My colleagues were giving me shit back then. They're like, Dr. Tina thinks everybody has metabolic dysfunction. I was telling people 10 years ago online to eat meat and deadlift, eat steak and deadlift. And the big influencers at the time were like, you need to do yoga and go plant-based. And I was like, no, you need to eat.
It was a macrobiotic diet and yoga.
And I'm so excited that we finally have some messengers people are hearing. I totally commend Casey Means for getting the message out. I commend Gabrielle Lyon for getting the message out. Some of us have been beating this drum for a long time, and
this is chiropractic philosophy, if I may. This is if this is the foundation, this is why we were called, this is where the word health nut comes from. This is what chiropractors were called. We were called nuts.
Yep.
We were called the health nuts because we were talking to our patients about nutrition. We were talking to our patients about movement and exercise and mobility drills, all the stuff that's cool now, the deadlifts that are cool, right? The animal proteins that are, carnivore and whatever, and keto and all of that. That was all very foundational in terms of what made us different from the allopathic model.
Yep. Yeah. And your muscles are it. Your muscles are not just, they're not just movers. I mean, they're important movers, but they are a little endocrine organ system that we can build. And it's just absolutely non-negotiable. I've been saying that it's non-negotiable for 10 years, and I'm listening to others take the words out of my mouth and parrot it. And I'm glad the message is getting around. I'm not loving being plagiarized.